Welcome, everybody. Welcome to the finest city in the world. And we only give prizes to Scots. I don't know if that had been cleared. So those of you who are from the other three countries nominated, you can basically forget it. So everybody's winning prize. So no, you're very welcome. Thank you for coming and thank you for having me. This is a very civilised conference. It starts at 10 o'clock and lunch is at 12. I could get used to this kind of conference. This is ideal. In fact, the first speaker of the day is standing between you and lunch. That's the kind of conference I quite like. So I'll endeavour not to keep you too long. Our plan is to talk for a little while about lessons over the last 2 or 3 years from my perspective, because I'm your speaker. If you don't like them, then you can have some of your own. You'll have lost 45 minutes of your life, perhaps. And then I'm happy to take questions. And one of my colleagues over here will lead it. But the first thing I want to do is to patronise you. And many of you won't know. Where are the Scots in the room? Oh, there are some. So, first of all, I apologise for being on your telly every day for 2.5 years. I'm sorry. OK? Your granny, though, thinks I'm great. You don't. I understand that. But all the grandmothers in Scotland absolutely love me. So all the over 75s want photographs. So I'll be here at the end. If you want a picture for your granny, then I'm entirely happy to do that. The most common thing that happens to me is young people come up to me, young people, like under 50, say, "Are you Jason?" I said, yeah, I am. Thanks for saying hello. And they say, "My granny thinks you're great." I said, "OK, do you want a picture?" "Yeah, I would love a picture." I said, "It's not for you, though, is it? It's for your granny." Yep. Small children imitate me and grannies love me. I'll take it, though, if we've protected anybody. So the Scots in the room, I apologise. The other three countries in the room have absolutely no idea why you've asked this guy to speak at your conference, because they don't know they've absolutely no idea who I am. So it's a complete mystery to them. The patronising piece at the beginning, though, is to genuinely and sincerely thank you for the work you've done in the last 3 years. Now, I've been involved with hospices, particularly in Scotland, the Airdrie Hospice, in particular St Andrew's Hospice, and the children's hospice movement across Scotland for a number of years. And I've had policy responsibility for hospice care and hospice funding in the government. But my heart is inside hospices. I've had family members live, die and work inside your institutions. And during these 3 years, you've stepped up to another new environment. And I can't imagine, and this is a slightly odd sentence, but I can't imagine a once-in-100-year infectious disease pandemic without a hospice movement. Imagine how much worse it would have been for families and carers and others without you guys doing what you do, and those you represent, who, of course, I presume there are some hospices open today, are there? Are there other people still, there's people still working that you've left behind who didn't get a trip to Scotland. So thank you very much for everything you've done. It's genuinely appreciated. So this is Scotland. I thought we might do a little brief tourist introduction. Does anybody know where this is? It's the Glenfinnan Viaduct. That is Loch Finnan in the background. And, but those of you not from Scotland, perhaps, don't know it as the Glenfinnan Viaduct. You know it as the Harry Potter Bridge. So we're building a visitor centre here to fleece money from Americans and sell them Harry Potter-shaped whiskey bottles with shit whiskey in them to make money to build schools and libraries. It's a fantastic method of tourism, and here's the news, it works. So we are actually building a visitor centre because so many people were coming to take pictures of it that it was getting ruined. So we're building a visitor centre to sell keyrings and Giffen Droff, whatever they're called, capes and stuff. So this is what Scotland looks like on the 2 days a year it's not pissing with rain, but it's an absolutely beautiful country. It's genuinely beautiful, and I hope you get a chance when you're here, if you're visiting, to spend a bit of time don't miss the lectures, don't miss the exhibition hall, don't miss the lunch. Leave now for 40 minutes. No, please do see a little bit of the city and the country if you can. The hop-on, hop-off bus has a stop right here, so you can get it to Glasgow Green, you can get it to the Kelvingrove Art Gallery, you can walk to Kelvingrove Art Gallery and see one of the finest Dali paintings you ever see in your life. So there's lots to see and do, and I hope you will do that. But I'm afraid the reality of Scotland is not all Loch Finnan and beautiful green space. This is an 18-month-old boy He will almost certainly have seen violence. He probably from an addicted household. His house will be damp. He'll have no green space to ride his bike. His healthcare access, although free at the point of delivery, will be much worse than his cousin 4 miles up the road. He will die 25 years younger than his mates 4 miles away. Glasgow is a completely unique city in the Western world. In 4 miles, there's a 20 to 25-year life expectancy difference. It's astonishing, absolutely astonishing. If you take his blood cortisol levels today, he will be chronically stressed at 18 months. He won't know. He'll just be scared. He'll just live scared. And his pal in Bearsden, just 4 miles northwest, if you take his blood cortisol levels, they'll be normal. He'll have his heart attack and stroke at 85, and he'll probably get hospice care. This young man will have his heart and stroke attack at 40, and probably won't get hospice care. We have some of the most deep-seated post-industrial inequalities in the world, in the city you're sitting in. Nobody wants to be called something in public health, so they know if they use your city to name something, you know you're in trouble. So they call it the Glasgow effect. That's not something we should be proud of. But people come and study Glasgow because of that. This is part of how we're trying to fix it. So this is the Scottish National Health Service. So if you're visiting, including my two colleagues at the table here, you are forbidden from ever saying the NHS ever again in your whole lives. There are 4. They are entirely different. The terms and conditions of the workers are different. The organisational paths are different. We don't have integrated care boards. We've had integrated care systems since 2016. So we at Wales, again, entirely different. Northern Ireland, well, nobody's entirely sure, but there's a National Health Service, but there's no government, so it's a little bit tricky. But this is ours. 13, depends how you count the money, 13 to 19 billion, 3 regions, 14 health boards, all of which have a different tartan from space. I'm not sure if you knew. This is what Scotland looks like from the Artemis probe. I'm not. So each of the tartans is a different health board, and inside that health board is the whole of health and social care. So I can't take you to the chief executive of Glasgow Royal Infirmary. That person doesn't exist. There isn't a chief executive of Glasgow Royal Infirmary. There's a chief executive of the population of Greater Glasgow and Clyde. You see the difference? So they happen to have hospitals, and they happen to have primary care, and they happen to have public health and dentistry and everything else, but there's no chief executive of the individual hospital. We have no trusts. We had trusts for about an hour and a half and realised it was a bad idea and got rid of them overnight. But we also have huge differences in the scale of what we're trying to do. So you're in Glasgow, 1.5 million people, 4 massive hospitals, the biggest new build in 20 years across Europe, 10,000 staff. It's called if you ask a taxi driver to take you to the Death Star, that's where they'll take you. Because it's a big cross from above, and the taxi drivers call it the Death Star. I'm not sure we should be proud of that, but it's where they'll take you. So we have that. Urban Manchester, Birmingham, Liverpool looks the same. But then we have Shetland. You see it top right? It's illegal in Scotland now to show Shetland in a wee box. You remember the old maps when Shetland was in a wee box? You get to jail for that now. So that's Shetland where it should be, closer to Norway than it is to Edinburgh. And if the Norwegians want to provide the healthcare there, I'd be very grateful. 19,000 people on a windswept island in the middle of nowhere who all get sick. So our only chance is fixed-wing aircrafts. The ferries take a day to get there, if they go. There's been no ferry to Shetland in the last 3 days. We haven't been able to get a ferry to Shetland for 72 hours because of the weather. So you can see the challenges of trying to provide healthcare on those environments. And now let's think about what hospice care looks like in these islands and mainland of Scotland. Hugely challenging. Barra, over here, smallest island that we have a hospital on. We've got a 3-bed hospital on Barra. I was just there. You land on the beach. It's the only scheduled flight in Europe that lands and takes off from the sand with Loganair, and there's a 3-bedded hospital there. So think about trying to provide end-of-life care in those environments. So let's think about, that was your introduction to Scotland, and let's now think about lessons. I think transferable lessons that I've learned from the pandemic, but let's see if they apply to you. So these are my 3 lessons, and then we're going to do them in order. They get a little bit shorter as time passes, so you don't have to worry if I'm too long on the first one, I promise. So my first is to understand the problem you face. So it sounds awfully straightforward, but I think we often misunderstand the challenge we're faced with, and we try and do too much. We try and manage up or manage down, and we can't. We can only optimise the piece of the puzzle we're given. So don't try and fix everybody else's problem. You're not the Chief Executive of Hospice UK. He is. So that's his problem. He needs to optimise that bit. You're not the Chief Exec of the thing you're running, or maybe you are. So optimise the bit you're in charge of. So in February 2020, I was the National Clinical Director of the health system here. So in England, I'm the closest you've got to Steve Powis, who's your NHS Medical Director in England. And I was helping run a big piece of the puzzle: safety, quality, cancer, palliative and end-of-life care, from a policy perspective. I was a dentist and then a head and neck surgeon for 20 years, just in the hospitals in this part of the world. And then Wuhan happened, and somebody phoned and said, there's this infectious disease, and we get 30,000 of these a year, and we ignore them, and we think there's nothing to it. The WHO look at 30 of them a year, and occasionally they send us a little email that says, maybe this one looks like something, and we think, yeah, you tell us that all the time. It comes to nothing. Well, this time it did, and it did in a big way. Northern Italy was probably our first real warning, where we saw, if you remember on the news, you remember the people dying outside intensive care units because there was no beds. Remember field hospitals in car parks in Northern Italy. And then Northern Italy took all the middle-class skiers from Scotland and gave them COVID, and they all came home to Scotland. Unbeknown, of course, to them and to us. And it was seeded into our population, just like it was seeded into every other population in the world. Our response looks a little bit like this. Now, this is a little bit retrospective, and we didn't come up with the framing for a few weeks, because in February, nobody knew what the heck it was. But this is where we ended up. So this is trying to understand the actual problem. And the complexity of a pandemic response, unfortunately, is much harder than just harm number one. Harm number one is the Chief Medical Officer, the Chief Nurse, and me. We are the leads for harm number one, which is COVID harm. So COVID harm is the number of people who have died and suffered miserably from this single disease. So we understand that. We kind of understand how many people have had it, roughly 615 million positive tests across the world, about 6.5 million deaths in the official UN figures. That's death certificate with COVID written on it. But remember, Somalia has no death certificates. Ethiopia has very bad death certification. Canada, America don't have, you get the idea. That data is hard to find. So the best estimate is a recent Lancet and Economist article that says, in short, 18 million are dead. So they took excess deaths for the previous 5 years, compared it with excess deaths of 2020 and 2021, and subtracted one from the other, and you get 18 million. So care, everything else should have been the same for those 2-year periods, but 18 million are dead of an infectious agent. It's complete and utter misery. There are no winners here. People in this room will have lost relatives. Some of you in this room will have long COVID. You'll have pals and relatives with chronic disease as a result of this infection, and we do not know why, and we don't know how to fix it yet. We will learn, and we will get better at it, but this virus didn't exist 3 years ago. So that's why it's so new. Think about how little we know even about some of the viruses we've had for decades. So harm number one, COVID harm. But now imagine you're Boris Johnson, terrifying, or Nicola Sturgeon, or Emmanuel Macron, or Olaf Scholz, and you're in a room, irrespective of what you think of their politics or them as human beings, you're in the room, you're at the seat of the head of the table, and I come in, or the punter who does my job comes in and says, right, here's the deal. There's a pandemic. Okay, we want to shut the country. Right, I'm not doing that. No, you've got to do that. You've got to shut the country. Put everybody in their houses. I don't care if you're in Detroit or Liverpool or Paris, you're going to put everybody in their houses. Okay, I'm Swedish. Well, you don't have to. That's not actually true. They did. They're just so nice in Sweden, they didn't have to make it the law. That's the difference in Sweden. Sweden just did as it was told. You imagine Scots doing as if we'd said, you're fine, do it if you like. What? I can go to the nightclub if I want to go. Oh, I think I'll just go. The Swedes, we told the Swedish people said, don't go to the nightclub, but I can go if I want. Yes, you can go if you want, but don't go. Okay, I won't go. What kind of society is that? It's weird. So, pretty much every country in the world shuts itself down. But here's the problem. Shutting causes 3 further buckets of harm. So you reduce harm number 1 because you get less death and less infection. But suddenly, because you stop cancer screening for 3 months, because you have to move all your workers in to deal with harm number 1, you've suddenly missed breast cancers and bowel screening and everything else, and cervical screening that you all know we've had to stop doing. We stopped cancer screening. I remember the day we gave the advice to stop cancer screening. Probably apart from the discharge of patients from hospital to care homes, probably the toughest piece of advice I've had to give during the whole 3-year period. So there's loads of harm 2 challenges. I'll show you a couple in a minute. Harm 3 is social harm. Those of you who watch BBC Breakfast or are Scottish will know Linda Bald. Linda Bald, the finest COVID communicator, I would argue, by some way. She was in charge of harm 3 in the meetings. Harm 3 is loneliness of the elderly, dying on your own, education of our young people being stopped, all of the social things that the response did. Now, you don't want to be in Sturgeon's seat anymore, do you? It's now got a little bit more complicated. And then the 4th harm is a guy called Gary Gillespie, who's Scotland's chief economist. You wouldn't put him on the radio phone-in, but he's a genius. He's the economist guy. And he says to Nicola Sturgeon, he says, OK, do what Jason says. That's good. Jason says, shut the schools, shut the schools. He says, shut the nightclubs, shut the nightclubs. Great. But here's what that'll do. Here's what that'll do to employment. Here's what that'll do to GDP. Here's what that'll do to business growth. And people will lose their businesses, and you'll have mental... You get the idea. So this is a Rubik's Cube. This is not a binary choice. It's not shut the country, don't shut the country. It's complexity layered on complexity. It's impossible. There's no folder on the wall that says, let's take the pandemic folder and decide what to do next. These conversations were terrible, really hard. And remember, at the beginning, the consensus scientific view was no vaccine for a decade. That was the consensus scientific view. You'll not get a vaccine for at least 10 years, if you're lucky. You might not get one at all. So the decisions at the beginning were all about trying to protect us from harm number 1, but at the same time limit harm number 2, 3, and 4. And that's what every country did. This is our framework. People did it slightly differently. So this is harm number 2. Planned and emergency care. So top line is emergency care, bottom line is planned admissions. We're still not back to the normal number of planned admissions, which means you're adding to the waiting list every day. Now, you always do that, but supply and demand is now out of kilter. So supply and demand is now meaning the time you are waiting is increasing. For every month we didn't do elective orthopaedics across Scotland, we add 6 months to the waiting times. For every month we don't do elective orthopaedics, we add 6 months to the waiting times. Some people are now waiting over 2 years. We're back in the good old days when I was a boy. Some people in this room look old enough to remember it. When I was a proper surgeon, and we used to have an acronym on our theatre lists that said died on waiting list. Died on waiting list. I mean, that had gone, but it's back. Harm number 3, this is just one example. This is kids' absence from school. Dark blue is normal absence. Off for a funeral, off for the flu, off because I fell off my skateboard. Light blue is COVID. So light blue is completely new kids off school, even when the schools are open. And remember, the schools were shut for a prolonged period. My wife's a teacher. She will tell you that she's an English as an additional language teacher for asylum seekers and refugees. So she will tell you that if your solution to the Eritrean immigrant population to teach them English is laptops from her dining room table, you can go in, I can't tell you what she would actually say to you, but it doesn't work. That is not the solution to teach the Pole, Eritrean and Ukrainian populations English. And then this is harm 4, economic harm. So this is crisis grants in Scottish social work. So you come, you apply for food on the table, clothes on your kids. It's a really high bar to get a crisis grant from social work, but it doubled during the COVID pandemic. The number of people seeking those grants doubled. That's just, I could show you GDP, I could show you employment, I could show you business loss, I could show you the restaurants that went bust in Scotland and Glasgow, but are now recovering. I could show you the soft play. Soft play, honestly, it brings me out in a cold sweat. I think we should have kept them shut forever. I have no children. It appears they're liked by parents. They are infectious cesspits. What on earth are you doing with your children in these ball pits? They come up holding snot from other children. But the other news is that it turns out, I don't know this for sure, I think they're run by money laundering gangsters. Because they were vitriolic. They were the toughest crowd of any industry. I spoke to every industry in the country repeatedly. Faith groups, nightclubs, the hospitality, hotels. Oh my word, soft play were hard. Flipping heck, there's only about 10 of them in the country. So number one is understand your problem. And unfortunately, when you lift the rock, it's usually more complex and complicated than you imagined. And actually sitting on the sidelines criticising your leader or criticising those below you are actually, when you look, it's probably harder than it looks. I'm not asking you to feel sorry for the politicians, but I'm glad I wasn't in the decision-making seat. I'm glad I was only an advisor to those decision-makers. So that might be crippling, though. So what might, I mean, one of the responses to that is just to stay under the duvet and not move, because flipping heck, it's all too hard. So that takes me to lesson number 2. And lesson number 2 is to lead, to step up. I don't care where you are or what you do, but there is something in your piece of the puzzle that you can do. There was I worked in America for an organisation called the Institute for Healthcare Improvement, IHI. And they are the global leaders in systems improvement in health and social care. So they're the people who came up with the healthcare safety bundles, the infection stuff that Scotland did. I'll show you a little bit of it later on if we've got time, although I'm telling too many stories, I might not get to. Unless you want to miss your lunch, because lunch is kind of early. No, I'm joking. So one of the things IHI did was they sent the Associate Medical Director for Mayo Clinic. Mayo Clinic's considered to be, by many, the finest health system in the world. It's fully private in America. There's a grand piano in the front hall. But anyway, it's proper high-end, and it's really good. And Steve, who's the medical director, is a lovely man. So he took some time off, and he went around the world looking at high-performing health systems. But his exam question was different from the usual exam question. It wasn't, how do the leaders do this? What's the organogram? How do they organise themselves? How is it funded? It was, how do individual leaders behave? That was his exam question. You got it? So he also wrote a thing about how you should organise your thing. But the piece that's really interesting and new is how do the leaders behave inside high-performing health systems? And he went to NHS Scotland, he went to pieces of NHS England, not the whole thing. He went to Jönköping in Sweden, he went to the Alaskan health system, which is by any measure probably the best health system in the world, all over the world. Singapore, okay. So let's go past that. I was going to tell a joke there, but let's go to here. So these are the high-impact leadership behaviours which he discovered, or he codified. He thought, and they're really simple, but they're worthy of a little bit of thought. And remember, they're about you. You can't direct these to somebody else. You can't say, well, the chief exec's not behaving like that. That's not the point. That's up to the nurse director to behave like the nurse director. If you are the band 5 in the hospice on the night shift, these apply to you just as they apply to the nurse director of a whole hospice system. So he saw these individual human behaviours in the leaders. So the first was person-centred care. I mean, can I skip this one for you guys? I mean, surely. This is you. This is your bread. This is what you do. This is what it's about. You might substitute family for person or whatever, but you get the idea. It's about those we serve, making sure they are in the centre of every decision that we make and do. This is a nurse in Kirkcaldy in Fife when I was allowed back out to visit again. And she was a big advocate of the What Matters to You movement. You might have seen it in Scotland, Norway started it, and now it has spread around the world. And it's just a simple, it can be above the bed, it can be in the conversation on admission, it can be in the hospice front hall, be any way you like. But it's just a really simple mechanism for asking patients and kind of ensuring we ask patients and families what it is that matters to them. And it's rarely chemotherapy. They rarely say chemotherapy. They usually say Rangers, or Celtic, or steak pie, or my granny, or my grandkids, or some yoghurt. My dog often comes up. Xboxes for anybody under 20. So it's just a way of thinking about it. This is another visit. This was the new health secretary. So if you imagine your job is hard, imagine in the middle of a pandemic, the First Minister of the country approaches you and says, I'd like you to be the health secretary. What? I'm quite happy being the justice secretary. Yeah, it's fine, it's good. You'll love it. Nice people. But it's a pandemic, First Minister. You'll be fine. The last one lasted a year. You'll do at least a year. It's fine. So this is Hamza Yusuf, who's Scotland's present health secretary. And we're wandering around a hospital. So the second one is frontline engagement. If you're not in the front line, you can't understand what it is. And the front line isn't the caricatured front line. It could be the boardroom. If you haven't been in these tricky board meetings, that could be your front line. Or it could be more conventionally, where the patient and family meet the service. In Toyota, if you ever get the chance to go to a Toyota factory, you should do it. It's an astonishing visit to go on. In Toyota, at the production line, everywhere in the world, there are yellow footprints drawn on the floor. And if you're a manager and you want to go talk to the workers, or you want to have the quarterly meeting with the worker, whatever, you have to stand in the yellow footprints for an hour before you're allowed to speak. You get it? You've got to stand in the front line and understand the production line before you can say, mate, you're not working fast enough, or you're not being nice. Stand here, then tell me that I'm not going fast enough, because it turns out the spanner doesn't work, because the spanner's a bit rubbish. So if you get me a decent spanner, you get the idea. Imagine if we forced every health and social care manager in the world to walk and be in the front line for an hour before they had a meeting about us. That would change the dialogue a little bit, wouldn't it? Now, you can't just give it to other people, though. This is about you and me. So we've got to be in whatever that front line happens to be. So if you're not in community hospice and you're thinking, well, these people are not working very hard, why am I? Well, why don't you spend a day in the community hospice and work out what it feels like? Or, this is a little bit of a dodgy suggestion, if you're irritated by the politicians, why don't you phone one of them and ask them to shadow them for a day and go to their constituency surgery on a Friday and just sit at the back and watch what your local politician does for a living for 8 hours. And I guarantee you, you'll think differently about that politician and the job they're doing than before you went in. So walk in the shoes of those who are in the front line. The third was, I'm afraid, quite dull, but hard. It was relentless focus. It is constant rhythm. It's just, this is hard, and it's hard every day, and we're going to get up again, and we're going to do it again, and we're going to do it again. But what about the measurement? We haven't got them. Well, we're going to try again. And it's really tough. But he saw that in the leaders of the institutions who he went to see, that they didn't tire. They just kept going, and they tried to make it better every day. The chief exec of Jönköping County in Sweden is a really dear friend of mine, and they've got some of the best outcomes in the world. They run a system for about 250,000 people in eastern Sweden. And I said, how did you do this? How did you manage this? It's just incredible. And he said, in Swedish, of course, he said, we just did everything. I thought, that's not helpful. We just did everything. Fourth is tell the truth. So fourth is be completely transparent with patients, families, the media, everybody. Just get it out there. So this was quite early in the pandemic when FM and I were talking to, in Scotland we have a thing called Young Scot. Every young person in Scotland gets a card, gets them money off travel, gets them collecting coffee vouchers, but it also is a kind of club, a thing, so that it's got our best sexual health website in the country. It's got the best advice for debt. So it's a great way for FM and I to talk to young people. So that's what we were doing. We were doing a live Q&A with young people, asking each other the questions that they were sending in. So we did a huge amount of this. A lot of the media stuff you saw on the telly was just the tip of an iceberg of a lot of invisible media that we did with stakeholder groups, with faith groups, with young people, with gypsy traveller communities. So we tried as much as we could to be out there, whether they liked it or not, and just tell the truth. We had digital dashboards, we had analysis. You could look up in Scotland the postcode you lived in and find the number of positive cases. You get the idea. So whatever your piece of the puzzle is, Steve, when he went round, found transparency. And then the final piece of these 5 is a made-up American word, because he's American. It was boundarylessness. And I don't need to tell you this either, but this is working across that system. So you can't do hospice care without thinking about families, without thinking about the education service or the third sector or justice or whatever. And COVID was exactly the same. There's no way we could have done vaccination without Glasgow Central Mosque, which is just down there. It became our biggest vaccination centre. I remember the day we asked them, do you think you could maybe do vaccines? We had stopped our worship services. They weren't really speaking to us. And we said, look, we really need a vaccine centre in the southeast of the city. Is there any way you could do it? And they're still open. A year and a half later, still doing more vaccines than anybody else in the country, in their mosque. So you have to work across natural and significant boundaries if you're going to do this work. And you guys understand that better than anybody else. So this is Orkney, which is the one just closer to the mainland. And I went it was just when the vaccines had come. So it was 2 winters ago. It was about this time 2 years ago, 2020. And this guy was retired, Orcadian, been there his whole life, and he was on the door for basically 2 years of the vaccination centre. Stood at the door, rain or shine, and it rarely shines in Orkney. And he was just relentless. He volunteered, he looked after everybody. And I went in and I said, I haven't had my flu vaccine. Is there any flu vaccine on the premises? Because I'd quite like it. And nurse said immediately, yes, of course, come here. So she does the consent, and I think she's given me my vaccine. And, but behind her are a series of, and that's how we do vaccination now, to make it quicker. We've got consenter in the front and then punters in the back who can give you the vaccine. And this, well, let's call her, what will we call her? Curvaceous, this woman? She was big, okay? She was big. And she was a bus driver. And she was loving it. The National Clinical Director was going to get his vaccine from a bus driver. If she said she was a bus driver once, she said it 46 times. So there's pictures of me in the papers with a bus driver with a needle, like. It was a fantastic illustration of. So the transport system in Orkney had given over its bus drivers to be trained as vaccinators in order for us to get through the whole Orcadian population. We did the Orcadian population pretty much quicker than we did anybody else. They all came very obediently in 2 or 3 days. 19,000 people or something in a week, done with Frank at the door and the bus driver in the back giving out the vaccines. It was a terrific example of that boundarylessness. You also can't do COVID without every piece of the puzzle. The other lesson here is that emergency or key worker status is not just us. I've learned that the people working at ASDA's customer service are pretty much key workers. Those working on our electricity supply, those in our police and fire services, everywhere else. You can't do it without them, and you've got to respect and honour what they are. So that's my first 2 lessons. So understand and lead personally. Don't look for others to do it for you. They're not going to do it. Or they might do it, but it's a coincidence. It's not your problem. You've got to do it. And then my final one, and we'll try and do this a little bit sharp so we can have some questions, is have a method. Now, this is a lecture all of its own. So this is the core of quality improvement and person-centred care and analysis and statistical process control and everything else that people will know has happened in Scotland over the last little while. Deming is the father of this scientific method that drove systems change across US, Japanese companies and eventually ended up in the public sector in health and social care through that IHI organisation I just mentioned. The example often used is Kodak, because Kodak was the finest organisation in the world for one piece of the puzzle, but never changed and didn't become a digital organisation and failed. But it is not necessary to change because survival is not mandatory. Deming was a grumpy bugger from the 1950s. There's black and white YouTube videos of him, and he's very, very grumpy. But his method is brilliant. And that's what we've done in the safety programme in Scotland, in a whole lot of other stuff. And just last week I was here for the Children and Young People's Improvement Collaborative, which is a massive piece of work across all of Scotland's schools, doing literacy and numeracy and health and wellbeing across Scotland's schools using these types of methods. You need three things to make change happen. You need people with the will to do it. That's usually findable. It's usually not the whole room, but you can usually find them. You need the change ideas. You need the recipe for the change. Again, usually findable. Somebody's usually got an innovation that's available or something, or you can do some research, you can innovate. But you need execution. You need an implementation thing, and that's where everything fails. Pretty much everything fails. And you'll have examples of trying to do that yourself. Scale up and spread across a whole system like yours is pretty much impossible. NICE, you know NICE guidelines? So NICE guidelines are England and Wales, but we often take them so we don't have to redo them. Sometimes we take them and put a tartan wrapper on them and pretend they were ours, but actually they were NICE. So NICE sent a cardiac, so I still get them because I'm pretending to be a clinician. So they sent a 300-page cardiac guideline relatively recently. It's a massive thing about what you're meant to do with people with cardiac disease. All the evidence, all the drugs, all the thing. I mean, it was preposterous. And if the covering letter said, this isn't exactly what it said, but it said, look what the clever people have done. Good luck with implementation. That bit it did say. It said, best of luck with implementation. So their execution theory was luck. Brilliant. Absolutely brilliant. So that's this. So that is old system. So have you ever been on a short life working group? They're neither short life nor do any work. Are you familiar with these? I've been on thousands of these buggers. So you sit in a room, usually with people who actually know the system, because they've thought, well, we better get nurses. Because we better bring some nurses, because they understand. Okay, so we've got nurses and might even have a patient if we're really radical. But we sit in a room and we design the thing. Could be a new drug chart, could be a new admissions form, could be whatever you like. And then we usually meet every 6 weeks. And then 8 months later, we've produced our thing. You know you're in trouble because it's usually laminated. My wife's a teacher. If you stand still in my house, you get laminated. And then you send it out to the world and you implement it. How does that go for you? It's garbage. So NHS Tayside, 9 Wells Hospital, 2005. They're trying to implement early warning scoring in the hospital. Quick story. Early warning scoring charts. Like, what's your heart rate, what's your respiratory rate, what's your blood pressure? You get a score out of 5. If you're 0, you're dead. If you're a 5, you should be at home. Yep. And everything in the middle gets people to come and help you. So this is what they do. 9 months. They spend 9 months designing the early warning scoring chart for 9 Wells Hospital. They print, I kid you not, they print 200,000 copies. And on the Monday, Jerry, who's the chief exec, who's my pal, puts them into ward-level bundles, sends them out on a Monday morning, says, look what the clever people have done. Please implement. Guess how many are used? None. Even the people on the feckin' group didn't use them. Jerry kept them in a cupboard for years. He would show visitors. He'd say, this is how not to implement change. This is 200,000 copies of the form that nobody ever used. Jerry then went to IHI. That's where I met him. And he did a thing called the Safer Patients Initiative. And unfortunately, this is much harder. But now you go to the work. It's not anarchy. You still decide you want the early warning scoring chart. So there's a leadership choice. So it's not you get to do what you please. You get the early warning scoring chart, and you say, right, what's the plan? Well, we're going to go to maternity. And in maternity, you say, why didn't you use the form we gave you? We gave you the form, what's the matter with you? And they said, well, there was only space for 1 heart rate. We've got, in case you hadn't worked it out, we've got 2 heart rates in our patients. Oh, we never really thought of that. And then they went to renal and said to renal, why didn't you use our lovely, shiny, laminated early warning scoring chart? And they said, well, you're red, amber, green, we're renal. Everybody would have been dead on your thing. And they're all alive, so it doesn't work for us. We'd have been calling junior house officers every 3 minutes because your red is in the wrong place. Oh, really? Well, maybe we need a different one for renal than we need for maternity. No shit. Really? That's amazing. How long has it taken you to work that out? Well, 30 seconds, actually, but 2.5 years in reality. Why didn't you just ask us? We'd have told you. Long story short, within 6 months, Ninewells Hospital has a functional early warning scoring chart in every ward, in every patient, in every unit in the hospital, saving lives every single day, because they use the method that's much harder. You go to the work, you test it in the work, you measure it, you change it, you measure it, you change it. It's still hard, and it's still designed, so somebody has still decided that's the thing you're going to do, but that's what you get. So you choose your goal, you choose your method, and you do it with predictive iterative testing. And in 10 years of the Scottish Patient Safety Programme that was based on some of that work at Ninewells, you get a 13% reduction in mortality. There isn't any other country in the world with a 13% reduction in all-cause mortality from 2014 to 2018. This is surgical mortality. This is the British Journal of Surgery in 2019. So this is pre-safety programme. We then implement the checklist, which is this the right patient? Is it the right operation? Have they had their antibiotics? Is the X-ray up the right way around? I mean, it wasn't radical, and it plummets surgical mortality by 1/3. That's people alive who would be dead. 36% reduction in surgical mortality. There isn't another country in the world that can show the surgical checklist at scale in every hospital. It took us 3 years to implement the surgical checklist. The Canadians did it in a weekend and got no change in mortality. Funny that. So they sent their checklist to every surgeon in Canada and said, please implement when you start operating on Monday morning and let us know how you go on. And there was no change in mortality. Then they wrote an article in The Lancet that said the surgical checklist doesn't work. That's not true. Canadian implementation doesn't work. The checklist works if you implement it properly. So this is Gawande and I publishing the first countrywide article in surgical mortality reduction following the checklist. But the point is the implementation plan. The point is taking the thing and doing it at scale. And don't try and do the whole country at once. There was 2 surgeons in Shetland who wouldn't do it. I tried to give them to the Norwegians, but they wouldn't take them. It was a German and an Iraqi, and they hated each other and hated everybody else. It was tough. But they wouldn't do the checklist because they didn't make mistakes. And so we just ignored them for a while. And then eventually, they still wouldn't do it, still wouldn't do it, still wouldn't do it. Nurses refused to work, still wouldn't do it, still wouldn't do it. And then eventually, you have to regulate. So of all your surgeons, you get to the end, and you might have to regulate for 2. And that's what we did. But you don't start there. You start with hearts and minds and will and getting your peer group and having pizza and counting the numbers and seeing how everybody's done and talking about the stories of the endoscope that was dirty and we stopped using it because of the checklist. And you spread those stories around. So those are my 3 lessons. But I wanted to come back to why we were thinking about the things we're thinking about. So my 3 lessons are: understand your problem, and it's usually more difficult than you imagine. Lead personally, so step up, lead yourself, and then have some kind of method. It might not be the same method, but choose something. If you're going to make change, there are scientific studies and scientific evidence of how to do that change. You can learn it, just like you can learn palliative and end-of-life care, just like you can learn cardiology, but you have to learn it. You're not naturally good at changing. That's not how it works. So this is Westview Care Home in Shetland. So I have slagged off Shetland a wee bit, but it's actually a glorious place to visit. This is 40 miles from Lerwick. It's in the middle of nowhere. It's in a small village, and it's the only care home for 40 miles. There's 1 shop, 1 pub, and a care home. And it was where our first 7 people died. Remember the story of the skiers in northern Italy? They came back to Shetland, and one of them came to this part of Shetland, and the virus ended up in this care home. And the first 7 residents died of what we now call COVID-19. But when they died, it didn't even have a name. This was really, really early. Nobody knew what it was. I went to visit. I met the families. I met the staff. I met everybody who'd been involved. It was an astonishing, resilient community. But there was a young lady over here who wouldn't speak to me. She was dead quiet and she wasn't engaging. So I forced her to speak, and she was a Polish domestic. And she had lived in Shetland for years, but she was broken, completely broken by the whole experience. And she started to cry and tell me her experience. And the bus refused to take her to work because the community was scared of the disease. The shop wouldn't serve any social care workers. If you worked at the care home, you couldn't buy your bread and milk because the shop said, no, 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 we don't. Imagine that in a small, isolated community. It's just unthinkable, and repeated millions of times around the world. But since those initial 3 months of that first wave, once they understood the disease, once we could help them understand the disease, once we understood it, they didn't lose a single other resident. Not one. It was a joyous, optimistic, happy place when I went to visit, with, of course, the history and the misery and the storytelling of what had come before. But even the families who I met were optimistic and grateful for everything they'd done. My final piece of advice before questions is, though, if you don't know your 1980s science fiction movies, you should watch Back to the Future. It's one of the finest movies ever made. But if Doc ever puts you in the DeLorean and he asks you to choose where to go, then don't choose 2020 because it was shit. Thank you for listening.
So, Jason, I imagine you're not the kind of guy who wants to come sit here, are you? You want to keep walking about, yeah? I assume you do. Do you want to keep walking around?
Great.
Yeah, I thought you probably would. So, I've got many questions yet. I think people have been so entranced by what you had to say that they've not asked any questions. Personally, I've got PTSD, because you reminded me about wacky warehouses and my children emerging, covered in other people's body fluids and smelling of socks. It's just... I didn't want to go there, but I did. One of the things that I remember from COVID, when I was working in Birmingham, was the whole system came together in an extraordinary way it had never done before. We in the NHS, we wrapped our arms around the nursing homes, the care homes, nursing homes that were falling over. Community staff went in and ran them to keep them going, and so on. And then when the pandemic kind of went away, so did the partnership. I wonder, was that your experience here, or you managed to hang on to it?
I'm not sure it's quite as binary as that, but in summary, yes, that's happened. It feels, I've spent more time in care homes in the last 6 months than I've ever spent in my life. I've been in more hospices in the last 8 or 9 months than I've been in my life, because I've tried to go round and understand the system response a little bit more fully. And the difficulty now, of course, is we're not on one mission. The mission is too broad. We were all in one place. So the Chief Constable, the First Minister, the health, we were all facing in the same direction, and the whole of the population were facing in the same direction. That's not true anymore. We're now doing this great human endeavour of health and social care, but the criminal justice system is trying to catch up because the court system is behind and the education system is behind. And so it feels really hard. I hope that, so we're about to embark on the National Care Service in Scotland, which is the next step of our integrated care system. That will codify and formalise some of the relationships, and it will force some of those institutions to be pals. I think, though, underneath that, the relationships are better. I don't know if everybody would agree. Rami might be in the room from Chaz. I think the fundamental relationships locally, COVID has helped them in the main. But you then need the formal structures to come alongside and catch up with them. The two challenges that Tony mentioned in his opening, though, there's not enough money and not enough people. So if I'm running a hospice in Rutherglen and I haven't got enough people and I haven't got enough money, you can be as kind as you like to me, but I've got a fundamental structural problem that I can't resolve, and that's the big challenge politically and organisationally for us for the next certainly 2 or 3 years.
Okay. You mentioned what's happened in waiting lists and waiting times. Do we bring relentless focus that you talked about to try and bring those down, or do we actually have to think about doing things in a different way?
Yeah, both.
You know, in theory, there's about 15% of England is waiting for something, which
Yep.
I
So we've
find
got
astonishing.
we think 1 in 6 are waiting in Scotland for something or other. So some of that is absolutely essential and should be optimised. And so some of you may have heard of the Aravind eye care system. It's a system I've been to visit in India. They do more cataracts in a single theatre than we can do in a whole hospital. It's an astonishing place. They've got no infections. They make all their own kit. It's amazing. And we're building a similar Aravind-style ophthalmic theatre just in Clydebank at the Golden Jubilee, not far from here. So bits of that you can optimise, because it doesn't matter how you maybe don't want to do the hips need done, the cataracts need done. So that's just a factory. It's not very nice to talk about it like that, but it is. It's a factory. So we can do that. There's then this big chunk in the middle, which is, let's call it non-communicable diseases. It's the diabetics, it's the respiratory disease, that has all got worse. So length of stay is up 1.5 days across the whole of the Scottish National Health Service. That doesn't sound like much, but if you multiply 1.5 days by 15,000 beds, that's quite a lot of increase. And that's because this group is sicker than it was, and we've still got the same tech to make them better. They often don't need surgery. There's often just a medical challenge. But then this bit over here is the worst of all. This is the frail elderly who weren't allowed out their houses for 2 years, who lost support, whose cafes closed, whose day centres we shut. That bit, that's the bit that keeps me awake at night. Yeah. And that's why we've got ambulances queued outside our hospitals. And that's not a waiting times problem, that's a deconditioning problem. So the raw waiting time stuff, frankly, needs money and resource and people and stuff thrown at it. I can draw you an equation for the First Minister to say, if you give me 350 million, this is how many of them I can do. I mean, it's not exact, but it's approximate. But if you give me 350 million for this, I don't know, nobody knows what to do. This is the really hard bit. And that means optimising the whole system. It means hospice care. It means social care. We've got 18,000 people in Scotland waiting for a care package at home. Not waiting for, we've got 1,800 in hospital waiting for a care package, but we've got 18,000 in their own homes waiting for a care package. They're only going to head into here. They are coming. Unless you get that social care package fixed. And that means resourcing social care, it means paying for social care, it means reforming social care. That's the bit that no government in the world has. Maybe the Japanese, maybe the Singaporeans. Pretty much nobody has resolved that deconditioned elderly. I hate that. That's a horrible phrase. It's impersonal, but you understand what I mean.
You've kind of taken us back to where you started your talk, haven't you, in a sense, because while we're pretty good at pulling people out of the river of ill health, you need to go back and see what's pushing them in. So that integrated piece around education, around housing, et cetera, is really important to this, isn't it? So
I'm going to take you. So did you hear that? So that's the public health model of healthcare, right? I'm going to take it another level because I think it's wrong. And it's not me that thinks it's wrong. It's Sir Harry Burns who taught me that it was wrong, right? And here's the metaphor that I think works better. So the old-fashioned public health theory is the rubbish acute system. All it does is pull people out the river and fix them, right? And you just keep pulling the same guy out the river, but actually the fence is broken up here and they're falling in the river, so fix the fence, right? Great. It's a nice metaphor. It's not terrible. Sir Harry, who's my mentor, former CMO of the country and big public health thinker, he says, there's no fence and there's no people on the side. Forget it. Everybody's in the river all the feckin' time. We're all fucked. And there's barrels of oil, and there's stuff on fire, and there's cars, and there's all kinds of other stuff. What you've got to do is get in the river and help the folk that are in it, and you've got to give them the resilience. So you've got to help. Now, sometimes that might be a hip, but it might be addiction, it might be end-of-life care, it might be, but we're all in the river all the time. So we've got to give people the self-awareness, the self-care, 99% of care happens in folks' houses. Hospitals are repair shops. I mean, they're not actually the care. My mum's COPD is treated by her and my dad, with occasional visits to the guru in their lives of the general practitioner who they love. But he sees my mum four times a year and phones her every month. 99% more of the care is actually provided by my dad saying, "You sound like you've got a cough, should you up your inhalers?" They're in the river all the time. So we've got to provide them with the care and the support and everything they need, whether it's social care, whether it's hospice and end-of-life care, or whether it's acute care in the river.
Thank you. I'm bouncing around a bit because I've got quite a lot of questions flooding in now. I'm going to pick 2 or 3 out and just try and take them through to lunch, because I'm conscious, as Jason said, we don't stand between you and lunch. 600 hungry people, it's not good, is it? Great
when you
question
have the SEC
here.
lunch, you'll realise you should have stayed.
Actually, Toby's traumatised by the goulash in Liverpool, but that's another story. What's your top tip for successful implementation of integration for your English pals? That's the actual wording I've got here.
So it depends what they mean by integration. If you mean integration of systems, the secret is to get the 2 ends right at the same time. So you've got to give space for those in the front line. So let's take a social care, acute care example. So if it's a discharge problem, the hospital think it's social care's problem, social care think it's the hospital's problem because they can't get them out in time, or they can't manage them, or they don't get the drug list, or they don't get the imaging, so everybody just de-optimises. So you've got to get the actual workers to talk. It's rose-tinted glasses, but in the good old days when I was a boy, in the small hospital I worked in the south of Glasgow, I knew the GPs' names, I knew the pharmacists' names, I could talk to them, I knew where we were, I knew the care home leaders. So I did oral cancer, and I could say, look, I'll come tomorrow myself, I will come visit, but if you take him today, I promise I'll come and see him tomorrow. You won't be taking any more risk than you're taking today, etc. So that's relational, but then at some level, the leaders have got to protect you and make that happen for you. So there's got to be rooms with people in suits, men and women coming together to actually work out the structures of that. And that's all this crap about information governance, and we can't share this and we can't share. Get over yourself, honestly. My mum and dad couldn't care less. They think you already share, and yet but the medical record doesn't move to the care home. What? They presume the medical record moves to the care home, and we put all these artificial blocks in place. So we've got to fix all of that top bit. So I think it's optimising freedom in the front line, and then at the top end, you've got to force. And that's what we're trying to do with the National Care Service. That's why we think we need a bill. I rarely choose a parliamentary bill as implementation. But I think there is something in the care service that requires structural change that needs a parliamentary bill through the Scottish Parliament.
Okay, thank you. So, actually, the first question I got was about a bill, and it's one I have to put to you in this setting with these folks in this room. There is a live conversation in Scotland in Parliament about assisted dying. If that goes through, if that's accepted by Parliament, what will that do you think, in terms of the relationship between the Scottish NHS, the hospice movement? Where would we find a way through?
Yeah, it's a long way from going through Parliament. Remember, 2 different things. So the National Care Service Bill is a government bill going through, a bit like the Health and Care Bill for the UK Parliament for NHS England. We have the National Care Service Bill going through with a number of other things. But just as in Westminster, you can do what's called private members' bills. And there's a private members' bill going through the Scottish Parliament on assisted dying. And there's been a number of attempts over the years to do it. Margot MacDonald, who was terminally ill herself, is the most famous version, a wonderfully inspiring woman who died in service and was trying to put it through. It failed a couple of times. But now Liam, can't remember. So it's coming back through. It's not, private members' bills are not ready for the statute books. They never are. Because they don't have the lawyers, and they don't have the civil service, and they don't have the thing around them. But it is gathering momentum. It's certainly forcing the conversation at a political level and at a community level, and I think that's a worthy thing to do. I don't know where that will end up. At a minimum, I hope it ends up with a very mature conversation about a good death and palliative and end-of-life care being prioritised and really important. Because I work for the government, I'm not going to give you my personal view of what happens at the end. I think at the assisted dying end of it, I think it will be a free vote in Parliament, and it will be conscience. We're probably closer to it than we've been in the past with the present setup of the 129 members of the Scottish Parliament. But I hope whatever happens, the dialogue is mature, is person-centred and family-centred, and talks about it. I think we're a long way from being the first country in the UK to actually have an assisted dying bill.
Okay, thank you. One last thing then, because we've got 2 minutes left. I noticed you mentioned as well your connection with IHI, and you did some work with Don, didn't you, Don Berwick? I remember Don came to Birmingham once, and we gathered the great and the good and the not so great and good around a table. And somebody asked him a question about how we should get together and work better together, expecting the kind of, you know, structural response. And Don looked at this guy, chief exec of a very large trust, and said, just do what you do with love. How does that resonate with you?
So Berwick is my hero. We were speaking at a thing in a couple of weeks' time. So we were on a prep call last night, he and I, and we haven't seen each other for a few weeks, so he's on, and this young boy comes on. This is Don Berwick, right? For those of you who don't know him, people touch him as he walks past. I mean, he's like the guru of healthcare systems improvement. He's a hero. But he's in his early 70s and semi-retired, and so this young boy comes on, and he's teaching us how to use MS Teams. And he says to Professor Donald Berwick, the inventor of Obamacare, says, have you done a webinar before? And if he'd said that to me, I'd have said, you're a fucking idiot. Of course I've done. And Berwick says, yes, done a few, thanks. But you could maybe talk me through it. The most gracious, lovely man, just the most beautiful response in the world. So yes, he lives it, and he's right. He's also been the head of CMS in the American government. I mean, he's got a spine. He's not scared to stand up to your big boy chief exec if that's what it needs. But the core of what he does is grace and love and kindness. And if you can start there, you still need the Excel spreadsheet that says there's no money and I need 4 more band 5s. Yeah. Could you flipping get your... That still needs to happen. But if you're doing that from a place of kindness and love and a core desire to make it better for those we serve, I think that's good advice.
Fantastic, Jason. Thank you so much for stimulating.